case presentation for adult onset of anxiety and depression in African American male survivors of childhood sexual abuse. Charles Tripp Tucker is a 54-year-old male with a history of anxiety and depression secondary to childhood sexual abuse when he was 6 years old. The way CCT was assessed when he presented for mental health treatment was using the Illinois Medicaid Comprehensive Assessment Tool, or IM plus CANS. This is an assessment tool that was developed jointly through the Department of Human Services and the Illinois Department of Healthcare. The IM plus CANS tool is based on the theory of was based on TCOM, a theory that is client-centered and based on determining the needs and strengths of a client presenting for services. What this theory does is it allows a clinician to use the assessment data to guide their treatment process. In Illinois, this is what is known as an integrative assessment and treatment plan, or an IATP. The IM-CANS is the first part of the assessment and treatment plan. The second part of the integrative assessment and treatment plan is the Illinois Care Plan, or the Illinois Inpatient Care Plan. In the case of CCT, it was a Illinois Care Plan. But basically what the TCOM does is it allows the use of assessment data to guide treatment and therefore leading hopefully to more successful treatment outcomes and better overall service delivery. Other assessments used in CCT's case would include the PHQ-9 and the GAD-7. These were used to assess the client's level of depression and anxiety once the cans determined that they probably had those disorders. As far as treatment goes, I, as his clinician, decided to use a therapeutic technique or therapeutic orientation called person-centered therapy. This was developed by Carl Rogers in the 1940s and focused on the idea that people in mental health treatment are intrinsically motivated to improve their psychological well-being, and more importantly, that those people are also their own expert in their own mental health. My job as a person-centered therapist in this case was to provide a safe, non-judgmental environment where the client could explore their own recovery. In addition to using specifically the person-centered treatment model, I also use a treatment model called assimilative integrated psychotherapy. This is a newer model that basically allows the clinician to borrow from other therapeutic modalities and orientations as needed to best meet the needs of the client. However, how it differs from integrated therapy, which is also a type of psychotherapy, is that when you add the assimilation piece, the therapist has a core therapeutic orientation that they're using. In my case, it was the person-centered therapy. And I borrowed, on occasion, techniques and skills from therapies such as CBT and solution-focused brief therapy. As far as how this client's treatment outcomes are assessed, the agency uses primarily a test-retest model. As I said, when a person presents for services, they are first assessed using the IM CANS, and if they're in crisis, as this client was, the IM CAT, which is a subset of the IM CANS. And then a Illinois care plan is developed. After 180 days, Illinois Medicaid requires that IM CANS be repeated and the Illinois care plan updated. In the case of CCT, I also periodically administer tests like the GAD-7 and the PHQ-9 to assess his level of anxiety and depression at the current time. It is also important to note that in Illinois, Medicaid requires that the IMCANs be administered again prior to treatment discharge, and the Illinois Care Plan updated to reflect that all treatment goals have been met. In the case of CCT, this is not the stage of treatment he's at because of recent life stressors. One micro practice topic that is central to the case of CCT is the stigma surrounding the reporting of any kind of male sexual victimization, whether it be childhood sexual abuse, as in this case, or childhood sexual assault of a male victim. And also the reluctance of male survivors to engage in mental health services and the stigma surrounding that. What I propose is that a pre-recorded educational training be developed for both the legal community and the mental health community, and to teach them about the stigma surrounding male sexual abuse and or sexual assault. This training would involve understanding what stigma is, would involve understanding how common the act of male sexual violence is, or how common, I should say, the act of sexual violence on males is. Because in our society, people think that sexual violence only happens to females. And the statistics would support that idea. 75% of all childhood sexual abuse victims are female. And 82 of those are under the age of 18. However, additionally, 24% of males have been victims of childhood sexual abuse in their lifetime. So, sexual victimization against males is a social problem that must be addressed, and therefore the two disciplines that have the most contact with victims or survivors must be better trained and prepared to deal with the issues that male survivors have in the context of this societal stigma. We will also deal with, in this training, we'll deal with the mental health and psychosocial things that come up for males, which are very similar to the things that come up for females. Males have to deal with shame, low self-esteem, sometimes hyper or hypo sexual response, an inability to attach to another adult intimate partner, which can lead to things like divorce, separation, And these are all things that both law enforcement and mental health professionals need to be aware of so they can better develop treatment programs and other services to help address the stigma and the issues around it of male sex crimes, or I should say of sex crimes on males. So that, in a nutshell, is what my case was about. I hope you enjoyed this presentation. Okay, please be